Hello everyone, this video is going to be about amniotic fluid and its disorders. First, let's learn about the basics of amniotic fluid. Amniotic fluid is also known as liquor amnii. It is a clear watery fluid present in amniotic cavity. The specific gravity of this fluid is between 1.008 to 1.01 and its osmolality is around 260 milliosmol per liter, and its pH is between 7 to 7.5, which means it is slightly alkaline, and this thing helps us to differentiate between premature rupture of membrane and vaginal discharge, because fluids from vaginal discharge have acidic pH, but in premature rupture of membrane, since it's the amniotic fluids that's coming out whose pH is alkaline. We can test this with nitrazine paper test. Nitrazine paper turns blue in alkaline pH, which suggests its premature rupture of membrane, and it remains yellow in acidic pH, which suggests vaginal discharge. Volume of amniotic fluid is maximum at 34 to 36 weeks of gestation, which is around 1000 ml. After this, the volume declines and becomes around 800 ml in 40 weeks and 200 ml in 42 weeks of gestation. If the pregnancy continues, the volume keeps on declining. Hence, postpartum pregnancy is an important cause for oligohydramnios. Major contributors of amniotic fluid are maternal plasma during the early weeks, that is during first trimester. The process is through transudation of maternal plasma through placental membranes. Then it is fetal skin during 12 to 20 weeks of gestation, and after this, the major contributor becomes fetal urine, because the fetal skin starts to keratinize after 20 weeks. Overall, the major contributor is fetal urine. Amniotic fluid is kept in balance by the fetus by its swallowing action. Around 400 to 700 milliliter of liquor is swallowed by the fetus every day. Hence, swallowing defect in fetus can cause polyhydramnios. But remember, although the fetus swallows it, the amniotic fluid has no nutritive function, since it is 99% composed of water. So what are the functions of amniotic fluid then? It acts as a shock absorber, protecting the fetus from possible external injuries. It maintains an even temperature. The fluid distends the amniotic sac and thereby allows for growth of the fetus. It prevents umbilical cord compression, helps in dilatation of cervix during labor, and last but not the least, the fluid flushes the birth canal during vaginal delivery. So due to its aseptic and bactericidal action, it protects the fetus and prevents ascending infection to the uterine cavity. Normally, the amniotic fluid is colorless, but at times it is straw colored, possibly due to exfoliated lanugo and epidermal cells. Deviation from normal color has got clinical significance. Green colored amniotic fluid means it is meconium stent, which can be seen in fetal distress, breech presentation or transverse lie, and listeria infection. Golden color means it is bilirubin stent, which is seen in Rh isoimmunization. Tobacco juice color is seen in intrauterine fetal death. Saffron color or yellowish green in postpartum or postdated pregnancy. Dark maroon color is seen in concealed hemorrhage due to abruptio placenta. Best investigation to measure the amniotic fluid volume is USG or ultrasound. Here two parameters are used. First one is amniotic fluid index or AFI. To calculate AFI, we divide abdominal ultrasound into 4 quadrants. Then we measure the largest vertical pocket in each quadrant. Remember, it's the vertical pocket, not the horizontal pockets. Then we add all those and the result we get is amniotic fluid index. Normal AFI is between 5 to 24 cm. So if AFI is less than 5, it's oligohydramnios, and if it's more than 24 cm, it's polyhydramnios. This method is not the most sensitive method and cannot be used in twin pregnancies. Next parameter is single largest vertical pocket or single deepest pocket. It is the most sensitive method. Here, instead of dividing the abdomen into quadrants, we directly measure the length of a single deepest vertical pocket that could be lying in any quadrant. Normal length is between 2 to 8 cm. So if the value is less than 2 cm, it's oligohydramnios, and if it's more than 8 cm, it's polyhydramnios. And this method can be used for twin pregnancies as well. Based on quantitative definition, oligohydramnios is when volume is less than 200 milliliter, and polyhydramnios is when volume is more than 2 liter. Based on clinical definition, oligohydramnios is when height of the uterus is less than that of period of gestation, and polyhydramnios is when height of the uterus is more than the period of gestation. Now let's talk about polyhydramnios in detail. We already know polyhydramnios is when AFI is more than 24 cm, or STP is more than 8 cm, or amniotic fluid is more than 2 liter. Etiology of polyhydramnios can be divided into three headings. First is polyuria of fetus, because if the urine production is high, more amniotic fluid is produced. The causes are multifetal pregnancies, twin-to-twin transfusion syndrome. In maternal diabetes, there is also fetal hyperglycemia, which can cause polyuria. In severe fetal anemia, cardiac output is increased, hence there is chances of heart failure. So to prevent that, compensatory polyuria occurs. And the last cause is hydrops fetalis. Next heading is fetal swallowing defects, which includes GIT anomalies like esophageal atresia, duodenal atresia, intestinal obstruction, and congenital diaphragmatic hernia. Neural tube defects like anencephaly and spina bifida can also cause polyhydramnios. Other causes are infection from parvovirus B19 that causes fetal anemia and hence polyhydramnios with mechanism we already talked about. Trisomy 21, trisomy 18, and chorangioma of placenta can also cause polyhydramnios. What are the effects of polyhydramnios? First is, due to distension of amniotic sac, the membranes get stretched. This causes production of prostaglandins leading to preterm labor or premature rupture of membrane. Over-distension of membranes leads to its rupture, causing the huge amount of fluids leak at once. So the uterus shrinks suddenly, leading to abruptio placenta and also dry labor. There is also chances of postpartum hemorrhage, malpresentation, and maternal distress for which serial amniocentesis is done. Now, the treatment modalities for polyhydramnios include bed rest for mild polyhydramnios where STP is between 8 to 11 cm. Amniocentesis can be done to relieve the maternal distress. Slow decompression is done at the rate of 500 ml per hour to reduce the chances of accidental hemorrhage. If fetal abnormalities are found, termination of pregnancy should be done. About oligohydramnios, it is when AFI is less than 5 cm or STP is less than 2 cm or amniotic fluid volume is less than 200 ml. Etiologies are those that reduces the amount of urine formation from the fetus. It includes fetal renal problems like renal agenesis, posterior urethral valve, and Porter's sequence. Then there is uteroplacental insufficiency, where there is decreased blood going to the fetus that corresponds to decreased renal blood flow to fetus, which decreases the GFR, causing oliguria and hence oligohydramnios. Causes of uteroplacental insufficiency are pregnancy-induced hypertension or preeclampsia. Here, increase in blood pressure leads to decrease in volume of blood flowing to placenta because we know pressure is inversely proportional to volume. Other causes are intrauterine growth restriction, postpartum pregnancy, premature rupture of membrane, and torch infection. The effects of oligohydramnios are: number one, if it occurs early in pregnancy, there will be less space for fetus to grow. This can lead to pulmonary hyperplasia and limb defects. If it occurs late in pregnancy, there is chances of cord compression, fetal distress, because of which the fetus passes meconium and swallows it, leading to meconium aspiration syndrome. Less amniotic fluid means limited mobility of the fetus, hence it can cause malpresentation. And lastly, this can also cause dry labor. For the management of oligohydramnios, amnio infusion is found to improve neonatal outcome. Thank you.